Hello, and thank you for taking the time to learn about the roux-en-y gastric bypass. If you're watching this, you or someone you care about may be considering weight loss surgery, and that's a big decision. My goal is to walk you through this operation in a way that's clear, honest, and grounded in real data so that you understand exactly what it is, how it works, and what life looks like afterwards. The roux-en-y gastric bypass, often just called the gastric bypass, has been performed since 1971. And it's considered the gold standard of bariatric surgery. It has the longest track record of any modern weight loss operation, and it's still the procedure against which all others are measured. Today, it's the second most commonly performed bariatric surgery worldwide, right behind the sleeve gastrectomy. In this video, we'll talk about who qualifies, what the anatomy looks like, what actually happens during surgery, how the operation works on a hormonal and metabolic level, the results you can expect, the risks and the complications, how it compares to other procedures, and what life looks like afterwards. Not everyone with excess weight is a candidate for surgery. Current guidelines recommend bariatric surgery for people whose BMI is 35 or higher, regardless of other conditions, and for people who have a BMI between 30 and 35 who have metabolic diseases like type 2 diabetes, high blood pressure, or sleep apnea that haven't improved with lifestyle or medication. For individuals of Asian descent, the threshold is lower, generally a BMI of 27.5 or above. Before surgery, you'll go through a full evaluation, including nutritional counseling, a psychological assessment, blood work, and sometimes an upper endoscopy. Some insurance plans require a supervised weight loss program before approval. Certain conditions like severe heart or lung disease, active cancer, uncontrolled substance abuse, or planned pregnancy in the next 1 or 2 years may delay or prevent surgery. To understand gastric bypass, it helps to picture your digestive anatomy. The stomach is a J-shaped muscular organ that holds about 1,000 to 1,500 milliliters of food, roughly the size of a football. Below it is the small intestine, about 20 feet long, where most digestion and nutrient absorption occurs. The first part is the duodenum, where bile and the pancreatic enzymes mix with the food. The middle section is the jejunum, and the final section is the ileum. The ligament of Treitz marks the transition from the duodenum to the jejunum, and it's an important landmark during surgery. In a gastric bypass, we rearrange the plumbing. We create a tiny stomach pouch and connect it directly to the middle portion of the small intestine, bypassing most of the stomach and the entire duodenum. Food takes a shortcut, and digestive juices don't mix with it until further downstream. That rerouting is a major part of how the operation works. The surgery is performed laparoscopically through 5 or 6 small incisions. First, we'll create a small gastric pouch, about 15 to 30 milliliters, roughly the size of an egg or a golf ball. The rest of the stomach stays in place, but it no longer receives food. Next, we divide the jejunum about 50 to 100 centimeters, which is about 20 to 40 inches, below the ligament of Treitz. The lower end of that divided intestine is called the roux limb, and it's brought up and connected to the gastric pouch. This connection is called the gastrojejunostomy. The upper end of the divided intestine, called the biliopancreatic limb, carries bile and pancreatic enzymes. We connect that limb to the roux limb about 150 centimeters, which is about 40 to 60 inches, downstream at the jejunojejunostomy, or the second connection. Below that point is the common channel, and that's where most nutrient absorption now occurs. Finally, we close the mesenteric defects. These are small spaces that are created during the rearrangement of the intestines so that we reduce the risk of internal hernias. The procedure takes about 60 to 90 minutes. Most patients stay 1 to 2 nights in the hospital and return to normal activities within 2 to 4 weeks. For years, people thought gastric bypass worked mainly by restricting food and causing some malabsorption. We now know that the hormonal changes are even more important. The small pouch does limit how much you can eat, at least early on. Meals may be just a few tablespoons. They eventually increase up to half a cup or a cup, but the real power comes from the hormonal shifts. When the food bypasses the stomach and the duodenum, it arrives rapidly into the jejunum, and it triggers a surge in hormones like GLP-1 and PYY. GLP-1 levels rise dramatically within the first week and stay elevated for years. PYY levels also increase. These hormones tell your brain that you're full and satisfied. Ghrelin, which is the hunger hormone, tends to decrease, especially early on, and the rapid nutrient delivery to the small intestine improves insulin sensitivity and stimulates insulin secretion, which is why many patients with type 2 diabetes see blood sugar improvements within days. And this is long before they get any major weight loss. Changes in bile acids and the gut microbiome also contribute to this, but these mechanisms are still being studied further. The gastric bypass doesn't just change your anatomy, it reprograms the hormonal signals that control hunger, fullness, metabolism, and blood sugar. In terms of results, patients typically lose 28 to 35% of their total body weight, with maximum weight loss around 18 to 24 months. That translates to about 60 to 70% of your extra weight. Long-term data are strong. The Swedish obesity subject study showed more than 25% total body weight loss maintained at 15 to 20 years. And a Swedish registry of nearly 30,000 patients showed 24.6% total body weight loss at 10 years. Health improvements are also very dramatic. Type 2 diabetes improves or resolves in 80 to 99% of patients early on, with long-term remission in about 30 to 54% at 10 or more years. High blood pressure improves or resolves in 68 to 95%. Sleep apnea resolves in 77 to 97%. Reflux improves in about 97%. That's a major advantage over sleeve gastrectomy. Cholesterol and triglycerides improve significantly, and these improvements translate into a longer life. A meta-analysis of nearly 175,000 patients showed about a 50% reduction in all-cause mortality and a median life expectancy gain of about 6 years, and more than 9 years for patients with diabetes. Weight regain is an important topic to discuss honestly. After reaching your lowest weight, some regain is normal. On average, patients regain about 20 to 25% of the weight that they initially lost by years 5 to 7. About 18% regain more than 10% or more from their lowest weight. But even with that, most maintain at least a 25% total body weight loss for 10 to 15 years or more. Gastric bypass tends to be more durable than a sleeve gastrectomy. In a large study of nearly 20,000 patients, they found that sleeve patients were about twice as likely to experience significant weight regain, and factors associated with regain included missing follow-up visits, returning to high-calorie snacking or grazing, low physical activity, emotional eating, and binge eating. If regain occurs, options include dietary counseling, obesity medicines like GLP-1 receptor agonists, and in some cases, revisional surgery. Like any surgery, gastric bypass carries risks. The mortality rate is low, about 0.1 to 0.2%, which is similar to gallbladder surgery. Many complications include anastomotic leak, which occurs in about 0.5 to 1% and may require reoperation. Bleeding occurs in about 1 to 4%. Blood clots are a risk, so we use blood thinners and compression devices. Early bowel obstruction occurs in about 1%. Late complications, including marginal ulcers, in 10 to 16%, especially in smokers, NSAID users, and patients with diabetes. Internal hernias occur in 1 to 5% and can be dangerous if the intestine becomes trapped. Anastomotic strictures, where the connections become tight, occur in about 1 to 5% and are usually treated with endoscopic dilation. Dumping syndrome occurs in 10 to 50% of patients and is triggered by sugary or high-fat foods. Post-bariatric hypoglycemia affects about 30% to some degree, with severe episodes in about 1%. Gallstones develop in 7 to 16% of patients after rapid weight loss. And nutritional deficiencies are the most common long-term issue and require lifelong vitamin supplementation and follow-up. Compared to other procedures, the gastric bypass offers stronger diabetes control and better reflux relief than the sleeve gastrectomy, although it has slightly higher complication rates. The duodenal switch and the SADI S produce the greatest weight loss and the highest diabetes remission rates, but require the most intensive nutritional monitoring. The one anastomosis gastric bypass is simpler, but it carries a theoretical risk of bioreflux. The adjustable gastric band has largely fallen out of favor due to poor long-term outcomes. Life after surgery involves a staged diet progression. We normally put patients on liquids for 1 week after surgery, then we put them on pureed foods for another week, then soft mechanical foods for a week, and then finally we start them again on solid foods where they're advancing back to get back to their normal diet in about 6 to 8 weeks. Long-term success depends on eating small protein-focused meals, chewing well, avoiding liquid liquids with meals, staying hydrated, avoiding carbonated and sugary drinks, and taking vitamins every day. You'll need a bariatric multivitamin, calcium citrate, vitamin D, vitamin B12, and iron. Blood levels are checked regularly to prevent deficiencies. And exercise is essential, at least 150 minutes per week of moderate intensity exercise, and we recommend weightlifting or resistance training 4 days a week. Weight loss surgery changes your body quickly, and that can bring emotional changes too. Most patients experience improvements in mood and quality of life, but some experience new or worsening depression or anxiety. A Swedish registry study found antidepressant use increased by nearly 39% over 10 years after gastric bypass. There's also a small increased risk of substance use, including alcohol, which is absorbed much more rapidly after gastric bypass. Ongoing mental health support is important, especially if you have a history of mental health conditions or substance abuse. Roux-en-y gastric bypass remains the gold standard. It is safe, effective, and transformative. It's not magic, but it's powerful when paired with commitment. When you take your vitamins and stay active, avoid smoking and NSAIDs, and maintain long-term follow-up. If you're considering the surgery, schedule a consultation with our team, and we'll evaluate your individual situation, answer your questions, and help you determine whether a gastric bypass or another procedure is right for you. Thank you for watching. Be sure to see the other videos in this series where we discuss all the different procedures, and we look forward to supporting you in this journey. Real science, real surgery, real results.